Welcome. This presentation discusses the value of technical integration between physical and behavioral health care. Even as we live in today's technically advanced world, the typical community of healthcare providers in the United States is connected using a series of written prescriptions, referrals, and clinical notes. This type of paper-based system has contributed to higher healthcare costs and less effective patient care. To move the country forward, the White House established the Office of the National Coordinator for Health Information Technology, or ONC, to promote the development of a nationwide health IT infrastructure. The cornerstone of the ONC's effort is the development of the Nationwide Health Information Network, or NHIN, and an open-source software system called Connect to transmit electronic health records. Use of the NHIN Connect infrastructure is beginning to move forward at the state level with the development of state and state-designated entity health information exchanges under the state HIE program sponsored by the ONC. These HIEs are being supported with more than $1 billion in funding provided through the Department of Health and Human Services. Behavioral health is a critical but often overlooked area of healthcare. In support of this vital component of healthcare, the Substance Abuse and Mental Health Services Administration has made it a strategic initiative to ensure that the behavioral health provider network fully participates with the general healthcare delivery system in the adoption of health information technology. In support of this initiative, SAMHSA has sponsored the creation of OBITA, Open Source Behavioral Health Information Technology Architecture. The first project of this effort is the creation of an electronic behavioral health record system. The EBHR project has three main objectives. First, establishing interoperability between primary care and behavioral health providers. Secondly, establishing behavioral health data standards which are compatible with national treatment data standards. And finally, facilitating data sharing while protecting patient privacy, established under the Code of Federal Regulations, Title 42, Part 2, which are unique to the behavioral health area of treatment. By delivering these objectives, SAMHSA will provide guidance to the behavioral health community around the issues states, counties, and providers are expected to face in the move towards integrated HIEs. The benefits of physical and behavioral health data interoperability are significant, and the technology to effect this goal is within reach. One of the most significant problems that OBITA intends to address is that, like most medical specialties, behavioral health providers are often not the first provider that a patient sees. Many patients who receive substance abuse or mental health treatment are initially referred from their primary care provider. Yet, there is not currently a streamlined communication channel for primary care and behavioral health providers to share information regarding the care of a patient. The following story demonstrates how seamless the integration of physical and behavioral health services can be, and how the results of using standardized data increase the ability to coordinate care, improve outcomes, and lower overall healthcare costs. Our scenario begins with a patient coming into a primary care provider's office complaining of stress and sleeplessness. The primary care provider performs an initial evaluation of the new patient and collects information as they would for a general checkup. The physician suspects that the patient may have an anxiety issue and decides to administer a behavioral health short screening questionnaire. The questionnaire determines if the patient should proceed with a comprehensive behavioral health assessment. In this scenario, the screener results are positive, warranting a referral to a behavioral health specialist. To make the referral, the NHIN provider directory is accessed via computer and allows the physician and patient to work together to select a behavioral health provider. The system displays relevant provider information such as distance from the patient's home, capacity and utilization rates, and most importantly, the provider's performance and patient satisfaction ratings. On the screen, a map is presented showing the provider locations. The patient chooses a behavioral health specialist, and the primary care provider prepares an electronic consent document for the patient to sign. With the patient's consent received, the system is used to make an appointment with the behavioral health provider, and the patient's care records are transferred as a referral transaction from the primary care provider to the behavioral health provider's computer system through NHIN Connect. The referral transaction data contains the patient's demographic information, screening results, and payer eligibility information to dramatically streamline the continuity of care. With the referral appointment to the behavioral health provider scheduled, the action in our story shifts to the behavioral health provider's facility. Through the availability of the referred data, administrative work around patient intake is greatly reduced, and the provider is already well informed to the patient's condition. When the patient arrives, the behavioral health provider is ready to perform a more thorough behavioral health assessment. The cycle of care proceeds for this patient, and during the next several months, the behavioral health provider develops a treatment plan that addresses the scope of root causes of the anxiety disorder. Alcohol abuse is identified as one of the root causes of this patient's anxiety disorder, and the patient receives treatment services from the behavioral health provider for alcohol abuse and anxiety. As treatment encounters proceed, the patient's records are maintained in the behavioral health provider's system. The final demonstration of the power of integrating behavioral health providers into the HIE occurs when the patient revisits their original primary care provider's office for a follow-up. During the follow-up, the patient signs an electronic consent document giving the primary care provider access to the behavioral health provider's records that describe the treatments received, diagnosis, and discharge plan for the patient. Because the patient received treatment for alcohol abuse, privacy rules unique to substance abuse treatment established under the Code of Federal Regulations come into play. In this instance, the electronic consent document is a type compliant with 42 CFR Part 2 regulations. The patient's records are electronically imported into the primary care provider's electronic health record system in the form of a continuity of care document. The CCD informs the primary care provider on the patient's progress and enables a closed loop of coordinated care. The patient's physician discovers that along with various behavioral strategies, the behavioral health specialist prescribed 5 milligrams of Xanax. This information greatly reduces the chances of the patient's primary care physician prescribing a counterindicated medication. This active integration of behavioral health and primary care helps avoid missing treatment information and administrative rework that too often characterizes the siloed medical specialty stovepipes of care that exist today. Thank you for watching this presentation. The reality of this story is closer than you may think. SAMHSA's EBHR project is creating the technology, and a tremendous opportunity to implement exists with the state HIE program. Please come back to visit obuddy.org to follow the development of electronic behavioral health records and how state HIE efforts are shaping the behavioral health IT landscape.